Hello, I'm Mary Hosbrough, and I'm one of the facilitators for our I-CBT Fridays learning group. The video that you are about to see was from a Friday presentation discussing I-CBT and body dysmorphic disorder. Originally, there were two presenters, Lucy Grants and Margaret McCall. And Lucy did the first part of the presentation. And during Margaret's part of the presentation, there were a lot of technical difficulties. During that time, Frederick Ardema, one of the creators of I-CBT, had kind of jumped in and answered some questions about using I-CBT with BDD. And Margaret decided that she is going to re-record her portion of the webinar without all of the interruptions. So this presentation is just Lucy's part of the webinar. And then I'm also going to try to add in some of the comments and questions that Fred provided some information about as well. So Lucy Grants is an LMFT in Minneapolis, Minnesota. She was originally an art therapist and pivoted to treating OCD after discovering that her own seemingly intractable anxiety of 25 plus years was actually the primarily mental presentation of OCD. So while OCD has been the focus of Lucy's practice, she's become passionate about working with clients with BDD as well. And she's going to share with us now a bit about body dysmorphic disorder.
Okay, so just so everybody knows, my Greyhound just came in. This isn't how I thought he would appear in my presentation, but there he is. He's wearing a muzzle because he's got an owie that he keeps licking. So it's been quite the process trying to get him to stop licking that owie. Okay, so thanks everybody for coming. I hear some feedback.
I did hear the feedback as well. Maybe I'll ask everyone to mute themselves in case that helps.
Okay. So anyway, we're glad to be here presenting on BDD today. As I think probably everybody knows, it's really underserved. And I know for me, I haven't had much training, certainly in school, and I've had to find it on my own. So we wanted to do an overview first on BDD, and then, so I'm going to do that part, and then Margaret's going to talk about her case study using I-CBT and share with us the great process she's been going through. So yeah, like I was saying, I've had to do my own searching. I bet everybody else has too when they've had clients with BDD show up in their office. And it's really a shame because people really are suffering, and it's just seems like really profound suffering from what I can see, what my clients tell me. So I've got a few resources first, just so everybody can see what I'm drawing from. And I think if you want more information, I like these. The first one is Catherine Phillips. She's written 2 books on BDD, and she's done lots of research. So she's got a longer YouTube presentation. Oh, I think it's an hour long. And then there's, I went to see the BDD, one of the BDD presentations at the conference this last summer with Chris Tronson and Scott Granite. That was really great and good from to get a personal perspective too. And Scott Granite has also written a book. Incidentally, I will have a resource sheet that I'm going to provide that's going to have some book titles. It'll have these, some videos, a couple podcasts I like, and some other resources. It'll have the assessments, the assessment tools as well that I've come across. So another resource I've used is this video, Ugly Me, which also is really interesting and gives a good personal perspective as well. And then the BDD Foundation out of England is another great resource, and they also have some podcasts I like. So the DSM, let me see if I can move my little thing here. I can't, so I'm going to wing it. So the DSM, talks about how it's perceived flaws in physical appearance that appear slight or non-existent to others. So for an example, I have a client who talks about his skin being flabby. And what I think he's seeing is just regular aging, kind of deepening wrinkles. Or another client who thinks his cheeks are puffy, or I think it was puffy cheeks, and they're just kind of like, he's still young and he's got his nice collagen. So those are a couple examples. And then we'll see repetitive behaviors like, that we see typical, similar to OCD, checking, reassurance seeking, comparing, but also then the grooming and skin picking that are specific to BDD. And so if you go down to D, one thing to know about for diagnosis is that if somebody's got an eating disorder, so if the focus is on body fat, weight, and their eating disorder behaviors, then it would have an eating disorder diagnosis and not BDD, but the two can go hand in hand. We want to specify if muscle dysmorphia is a component, and this is generally in men, in which cases they think their muscles are really deficient and weak, but they might be really big and spend a lot of time at the gym. I'll talk a little more about that further down. And then we also want to specify insight, because of course that will impact how hard treatment is going to be if the insight is really delusional to that point, or if they've got relatively good insight. But probably, if you work with people with BDD, like what I found for sure is that the insight is much less than in OCD, which does make it more challenging. So prevalence, I was surprised by this, but the DSM says it's 2.4, which is double OCD, which again is like, why is this so undertreated? But that's another story. So then higher in women, a little bit higher in women, and higher for younger people. And then a lot of people won't disclose about BDD because there can be a lot of shame. And then they may also really perceive that the problem is physical and not mental health.
What's going on?
Well, and so cosmetic surgery is, you'll see a lot of people with BDD and getting cosmetic surgery.
I have an hour between my next client.
Oh, can you make?
I think somebody might have their sound on. Anyway, cosmetic surgery, and then these clinics will sometimes screen for BDD, which is really in their own best interest. Obviously, it's in the client's best interest, but it's in their best interest too, because clients are often dissatisfied with the results, and so they may seek legal action after. So focus, facial features, any facial feature, any body part, quality of the skin, in some cases body symmetry. And then, as I was talking about muscle dysmorphia, which can lead to other problems like some people might take steroids to get bigger, and then that can cause things like roid rage, or like muscle overuse issues. And then BDD by proxy, which I think also can exist with OCD, but transferring your BDD issues or perceived issues onto others. So something that comes up in my work with clients, but also I've talked to a few therapists who have BDD, And everybody talks about this deep sense of unworthiness and self-loathing, lots of shame. And one of my clients will talk about if he seeks reassurance, or if somebody just happens to say he looks nice or whatever, he just feels like people are lying. So he's always got this sense of being duped or humiliated. And then one therapist I talked to suggested a kind of dissociation from the body because there's so much self-loathing. I also thought this was interesting, that people with BDD are found in studies to have this aberrant visual processing in which they focus on tiny details at the expense of the whole. And of course, if you're focused on a tiny detail, that's going to make it seem more pronounced. And in research, they found it's not just physically or on themselves, it's also in this study, they did it on a house, and people would look at the house and focus on the details at the expense of the whole house. And I find this a lot too with clients, that they may misinterpret other people's facial expressions, assuming that they're disgusted or contemptuous and feeling like that's focused on them. So one of my clients has talked about getting on the bus and feeling like he's just repulsing people who get on. So this is, that's me. I don't have BDD, but I was inadvertently camouflaging, but I thought that was a funny example of camouflaging, which is a compulsion. This was an early pandemic picture when I was out running errands, and I looked in the mirror and I was like, you know, I look like the Invisible Man. Anyway, so similar to OCD, as I was saying before, there can be reassurance seeking, researching, lots of looking on social media, comparison, and sites like, I don't know what they are, but where they talk about the perfect face or the perfect proportions, which can lead to things like measuring, again, cosmetic surgery. Mirrors can be challenging because sometimes people will hyper focus on their appearance, and other times they'll avoid. So there's that, you know, middle place there where you have to try to help clients get to. And then I thought this was interesting too, that the skin picking, it can look like a BFRB, but it's actually trying to change the appearance. And it can actually be dangerous because sometimes people pick really far, and that can cause, you know, infections, and even, I don't know, one story I came across was something like somebody almost hit an artery or a vein or something. So you can get the level of how painful that must, you know, physically painful, not just emotionally painful. So an avoidance, and so it can sometimes be look like social anxiety because people are avoiding social situations. They may hide their video when conference calling, and then trying to read people's facial expressions when they're talking, which can really inhibit a, you know, social fluidity. So impairment relationships. I know some people are really hesitant to date, and like online dating can become compulsive. Education can be more difficult. Work is impacted. And then again, the social avoidance and misappraisal of people's facial expressions. General well-being, higher depression, more substance abuse, and apparently aggression. Then COVID, of course, as it was for many people, was really difficult, and people are faced with their own video, which I think can be distracting. I mean, I can see my video right now, and it's distracting. But to imagine also having BDD where you're just hyper focused on your appearance could be a real distraction, to say the least. And then high suicide rate, so 25% attempt and 0.3 follow through. So that's a really important piece. So when you're screening people with BDD, you want to get a sense of what the appearance concern is, what the feature they're worried about is, how long they're spending in their preoccupation, what kind of compulsions they're doing, and in what way it's impacting their distress and functioning. And so I've got this list of tools down at the bottom. I highlighted the BDD Y box mostly because that's what I've started using and I'm just most familiar with it, but I think they're all relevant and look at different, obviously relevant, but they look at different angles of BDD. So some of them are on insight level, I think the BABS. And I'll have that on the resource list also. Okay, so hopefully everybody saw the Facebook post about bringing art or bringing paper and something to draw or write with. But if you don't have anything right with you, it could be anything, it could be scratch paper. This is just to get an idea for this project. And I learned about this on the video Ugly Me. They use this as an assessment tool. Art can be used, of course, in many different ways, but I thought today we could use it kind of in the similar ways they do in that video, but I'm using a slightly different angle, and I'll explain more about that. So just know you don't have to be an artist and you don't have to share your art. So this is just for you. Please also just manage, if anything comes up, just, this doesn't have to be an intensity kind of project, and I don't want anybody to get terribly triggered, but it's just to get a feel for it. So what I'd like everyone to do, to whatever degree you're comfortable, draw a picture of yourself, either your face or your body, and show an exaggeration to yourself of a part that maybe you've been criticized about or that you feel you don't like, you feel flawed. So take just a minute to do that, please. And the idea with this is to get more of a feel inside what it might be like for somebody with BDD. Okay, so I don't know where everybody is with that, but you can just go ahead and finish up what you're working on. So I think that one of the things that really hits home for me is how much people, again, suffer, but also that it can be really constant for people, where some people, you just can't get away from it. It might be that they're not even looking at themselves and they're really focused on their appearance, or even camouflaging at home. One of my clients would pull a blanket up over her chin, which she doesn't like. Trying to think of other examples. Well, I think we probably get the picture of the level of distress for people. So for treatment, we want to do motivational interviewing at some points, partly because the insight can be low. So we want to increase people's motivation, and then exposure and response prevention, reducing research, again, managing mirrors, and then what you can do for people who want to get cosmetic surgery when it's actually BDD is ask them to delay, and just, what would it be like if you just wait until we're done with treatment and then give it, see where you are, and often they won't want it anymore. and treatment can be longer than OCD. There are some typical or common CBT approaches we can use. I'm not going to go over any since our focus is I-CBT, but treating the underlying depression can be really important. Looking at the core beliefs and schemas, and then retraining how people look at their face. So if they're used to looking at just parts, to help train them to mindfully look at the whole face, maybe describing the whole picture of their body or face. And then we'll be talking more about I-CBT, but one thing I would say with one of my clients who I've been working with for quite a while, I've been doing I-CBT with him, and he's really started to have more insight about his like when he's on the bridge. So he'll say, I can see I'm on the bridge and it's so compelling. But even that, just that he can see he's on the bridge is a really big change for him. And then again, since there is so much shame, we can look at, it's important to look at trauma, any issues in upbringing and environment, being teased and bullied. Sometimes it's helpful to have family members there. Psychoeducation can be helpful. Yeah, and again, just to emphasize, because I've heard this from a few different sources, that it is good to do some more deep therapeutic work. So in wrapping up, I got to thinking about this idea of looking at the parts instead of the whole. And I thought about my dog, we've met. So love this dog, heart and soul. And if I thought about my dog and his parts, all I would see is his big, huge, crazy long nose, his squishy, weird, bendy nose, his overall goofy, toothy, toothless even face, and his crazy overbite, and his long, skinny legs. What I would miss is this strikingly gorgeous, beautiful, beautiful dog who we love dearly and is fully self-expressed. And I got to thinking how that's really what we want for our clients, isn't it? To just be fully expressed in their bodies and not thinking about these, details. So thank you.
Okay, let's just see, what time are we at now? Okay, so we still have some time for her to come back, but I mean, what a great presentation, both from Lucy and also this case study with this, and you can sort of see like how devastating BDD is as a disorder, right? I mean, OCD is devastating for many people, but BDD is just the whole shame and the social aspect starts to come in even more strongly with, and especially with kids, and when it starts that young. So in a way, I think part of the reason why I-CBT it's sort of a good match for BDD as well is because I-CBT was originally developed for OCD with overwide ideation. So not even so much a doubt, more like a belief, a delusional belief to some extent. And you see that especially in BDD, where level of insight is often quite low, conviction level starts to approach that in most situations, that of a delusional conviction, which can be difficult to penetrate, but also can result in people often not being very eager to go into treatment because of the shame on the one hand, but also just talking about it is already quite difficult for people with BDD, but also because there's this conviction, they don't really believe they can be helped because they believe so much in the fact that there is something wrong with their appearance. I-CBT addresses that initial thought, really, like I am ugly, and I think even in general CBT they do. I mean Sabine Wilhelm wouldn't say this is just an intrusive thought, she would say like, okay, no, you have to address this idea, this initial idea as well of I'm ugly, not just the consequences. Like that's in the generally the case in OCD, right? But they say don't address the intrusion, just the appraisal of it. You know, I think in BDD that whole conceptualization falls apart because you have to address the initial idea, and in BDD, it's not so much a doubt; it's more like a belief, and it's especially self-evident that initial idea needs to be addressed. You cannot ignore this idea. It's actually part of the whole definition of BDD. If you look at DSM-5, what defines BDD? It's like it's an imagined defect or a very slight defect. They have sort of like this quantifier. It can be very slight, but highly exaggerated. There's definitely a delusional aspect to it, and I think that that in itself makes it for a good match, because I-CBT specifically addresses the imagination and the fact that these ideas, whether it's obsessional doubts or a delusional, in the case of an idea about appearance, it's based in the imagination, not in reality, not in real perception, and not in sensory, in normal sensory processing.
There are a couple questions in the chat. I'm wondering if Lucy or Fred, if you would be willing to look at those or see if they could be addressed. Or Fred, did you want to continue with what you were speaking about earlier?
Let's see, okay. Any questions for Lucy or for me where I can fill in? So go ahead. I see I didn't keep track of the chat, but
yeah, I'm looking as well.
I can ask. Hopefully, it'll just be quick comment. I'm also treating a teenager for body dysmorphic disorder. The difference that's something that's been kind of on my mind about it is just the criteria in the DSM being that it's a perceived flaw is so subjective. So I have a teenager who lives in a bigger body. So socially, she is perceived to be, she believes that her peers, perceive her as less attractive because of her bigger body size. So it's a very real thing for her that she gets a lot of reinforcement through media and through things that she hears her peers say. And yet, for me approaching it, I'm trying to be I am treating it as body dysmorphic disorder because it affects her life so negatively. And I am treating it as an imagined flaw in the service of being inclusive of a variety of body types, right? And so I guess I wanted to throw that out there. And if anybody else also struggles with that, like,
yeah, I struggle with like when I'm treating, because I try to tease apart like, so, because I mean, fat phobia is a really real thing, and like diet culture and all of these, like, what is body image? What is an eating disorder? What is BDD? And with a lot of people, I mean, I get kind of start overthinking, like when someone's talking to me about like size, not a feature, but about like body shape. I sometimes struggle with like, I don't know if that's why I would treat that as BDD.
Yeah. Lucy, you want to answer that, or you want me to comment on it?
I mean, I run into the same thing with a client I'm going through right now. I mean, I think technically that might be an eating disorder. I mean, but I mean, in my mind, I-CBT is useful still because of the level of distress about exactly what you're saying. It's like, it's because some people are in bigger bodies and are just fine with it, or they don't like it, but they're not distressed to that level, or they're not doing repetitive kinds of behaviors or avoidance, that kind of thing. So I tend to think of that as, whether it's eating disorder technically or BDD or OCD, it seems like I-CBT would be useful.
I think, obviously, I mean, body image disturbances that you see across a lot of different disorders, eating disorders, like Lucy said. At what point is this BDD, or when is this an eating disorder, or when is it just in sort of like preoccupation with one's appearance? I think that's probably highly prevalent, in probably more than 50% at one point, lifetime prevalence. You know, it's just as we're growing up and we can get preoccupied with our appearance. Entirely normal. At what point becomes that a BDD? At what point does that become a body image disturbance? I mean, on the one hand, there's sort of like this continuum idea. When it gets stronger and more severe, then we can start calling it a disorder of some kind. I think what's unique to BDD, and to differentiate it a little bit from other disorders, I would apply the same as how we differentiate OCD from other anxiety disorders, which just means that there's clearly something else, and I think that's in general how BDD is conceptualized. There is clearly something else going on than just an exaggerated fear of how you look. There's something happening out of context where, for some reason, it doesn't match reality anymore. And that sort of characteristics of BDD, I mean, you can see that when you start guessing, person, you know, they're coming in with BDD and start guessing what they have, don't guess, because it will never be what you think it is. You know, the person may have a big nose, but they have a obsession or a delusion about something entirely different, or a bodily preoccupation with something entirely different if it's BDD. So you have to be there is something, a mismatch with reality that goes beyond just an exaggeration of any flaw that somebody may have to some extent. You know, you see the same thing in OCD. It's the out of context occurrence of the obsession. It's not just an exaggerated fear of a possibility that something bad may happen in OCD. There's a mismatch with reality. There's a reasoning behind it that's sort of like creates this story about there being something wrong with me, or in the case of OCD, there's a problem of some kind that is not based on reality, that circumvents realities to an important extent, that sort of bends reality in order to make it fit by bringing all kinds of irrelevant associations, by bringing all kinds of histories in that but are not really directly relevant for what is there in the here and now. So that is how I would look at the difference, if that makes sense. Similar to how OCD is different from an anxiety disorder, so is BDD different because of that is really disconnected from reality. And you can get a feeling for that when you talk to somebody with BDD versus somebody who's just concerned with appearance. There's something else going on qualitatively, not just quantitatively.